Welcome to the Heart Rate Variability Podcast. Each week we talk about heart rate variability and how it can be used to improve your overall health and wellness. Please consider the information in this podcast for your informational use and not medical advice. Please see your medical provider to apply any of the strategies outlined in this episode. Heart Rate Variability Podcast is a production of Optimal LLC and Optimal HRV. Check us out at optimalhrv.com. Please enjoy the show. Welcome, friends, to the Heart Rate Variability Podcast. I am Matt Bennett, and I am here with a return guest, Dr. David Eddy. Dr. Eddy had a previous episode, which if you haven't listened to that one, I would actually go back and listen to that to learn about Dr. Eddy's journey with heart rate variability. We're going to touch on, substance use disorder here, and I know we talked about that in the last episode as well. So really encourage you to that, because today we are going to jump in to one of those research articles as somebody who probably obsessively, maybe more than any person else in the world, obsesses over HRV research. There's certain articles that generate secondary press. And when I say that, some articles, I think in grad school, Dr. Eddy, I was told that if you published an article in a journal, 10 people will read it if 5 of those are your family. So that was always like, wow, this is spectacular news to hear. But there's other articles that you see this in the research is people take these and hospital systems, healthcare systems, bloggers, really these key articles kind of catch like wildfire. And this is what's happened with your work, whether you know it or not. It is having a nice effect wide. So before we nerd out about your most recent work, just give us a quick introduction of you and a little bit about, your past work.
Sure, thanks, man. Thanks for having me back. I'm David Eddy. I'm a clinical psychologist at Massachusetts General Hospital, and I'm the associate director of clinical translational recovery science at the Recovery Research Institute at Mass General, where we do a lot of important addiction recovery related research. And I'm an assistant professor at Harvard Medical School as well.
Awesome. So the article is titled Heart Rate Variability Biofeedback for Substance Use Disorder, a randomized trial. Just I believe published officially this month, October 1st. That's right. Is the timestamp I had on it. So I was looking for, hey, what research is out there for the This Week in HRV episodes we started doing. And I'm like, not only found this one like absolutely powerful research, but a friend of the show as the lead author. So I'm excited to have you back. Let's just maybe get a little bit of background. I know this fits well into your previous work, but what was sort of the genesis behind, a randomized clinical trial, which is, a step up from, a feasibility study or other things that you often see in the research?
Right. Well, I've been studying heart rate variability biofeedback as an intervention for a number of years. And for those who are not familiar, I'm sure most of your listeners are, but for those who aren't, it's a breathing-based intervention where we train people using biofeedback to breathe at special frequencies that affects really big changes in the autonomic nervous system. And we've found downstream benefits in terms of improving mental health, stress management. One of the key findings I found over and over in early pilot studies of HRV biofeedback for substance use disorder is it can reduce craving as well, and anxiety and stress. And we always hypothesized that would probably translate into better substance use outcomes for folks in early recovery who have an abstinence goal, perhaps, or at least a goal of reducing their alcohol or other drug use. If we're managing their stress, their cravings, their anxiety, we hypothesized that would translate into better substance use outcomes. But we didn't really have that data. All the previous clinical trials we did were very small. They were pilot studies. We weren't really able to follow folks afterwards. And for one reason or another, we didn't have a lot of substance use outcomes that we could look at. And so in this study, I really wanted to extend that work with a phase 2 clinical trial. So the pilot studies had already established safety, there's preliminary signal of efficacy. There's definitely a signal that there's something going on here. There's probably, it seems like there's some benefit. So in a phase two trial, we want to sort of, use a bigger sample, expand the net a little wider, start to really test efficacy. And also in this phase two, I really wanted to, not just look at craving and negative affect like stress, craving, anxiety. I also wanted to see if, what we were seeing in previous study, those benefits in terms of, reductions in negative emotionality, negative
Yeah.
affect, is actually translating into better substance use outcomes. And so in this study, we looked at that other stuff as well, but it was really important to us to look at substance use outcomes as well, which we did.
Yeah. And so I almost have as many questions of this study with the control group. That was also like some fascinating. Usually the control group's just boring. But so some of these findings. So I'd love to just kind of talk a little bit about how just generally set up the study, the control group. Really well done from my perspective. But just kind of talk about what the study and what the participants of the study sort of did, both the experimental and control group.
Right, right. We really think about HRV biofeedback as having its most utility as an addendum to existing first line
Yeah.
treatments. So I've never really thought about HRV biofeedback as replacing cognitive behavioral therapy or medications. And I've
Yes.
always thought about it as an add-on tool that could really, it could cover some of the biological vulnerabilities of addiction and addiction recovery that are not covered by other treatments. But I never really thought about it as a replacement.
Right.
So in this study, what we wanted to do is we wanted to add HRV biofeedback to treatment as usual
Yes.
and then compare that to treatment as usual only. So in this way, sort of the study would have what we would call ecological validity. It would sort of map onto sort of how people would probably use this in the real world under real world conditions.
Yes.
And so we recruited a sample of people, about 120 people to begin with, and we randomized them to either HRV biofeedback plus treatment as usual or treatment as usual only. So for the treatment as usual part, the folks were just told, keep doing what you're doing.
Right.
Like you go into mutual help meetings, keep doing that. Doing the individual therapy, do that. Do your groups, do your medication, whatever you're doing. Like just keep doing what you're doing. Because we know in reality, people in addiction recovery are often doing multiple things
Right.
like that,
Exactly.
and we encourage that,
Yes.
clinically. Like,
Yeah.
I'm a clinical psychologist, and I tell my patients, like, you don't have to do a mutual help program, but like if it feels like that's a fit for you, great, add that
Yep.
on. Let's do that in addition to your psychotherapy with me. Like there's none of these things are contraindicated. There's just sort of
Exactly.
cumulative benefit generally
Yes.
for most folks. And so we wanted the study to have ecological validity. We wanted it to sort of track with how people would use it in the real world. Now, being a phase two trial, it wasn't really appropriate to be testing it against a standalone first line intervention like CBT. That's something
Yeah.
you would do in a phase three trial,
Okay.
assuming the phase two trial points to efficacy, there's a signal of benefit. And that's really this sort of phase two, phase one, two, three model. This comes from drug and device development,
Yeah.
right? In the research world, cancer trials, for instance, you may have heard about phase two, phase three cancer
Yeah.
trials. This is a standard progression of
Wow.
research that, we utilize to sort of reduce risk to participants and really bring the most rigor to testing and intervention. So that at the end of the pipeline, at the end of the process, we really can say with a high degree of confidence whether something, is going to work or not for
Right.
most people most of the time.
Absolutely. So let's talk about the biofeedback intervention as part of this. What did that look like in the study?
And so one of the other things I really wanted to do in this study was to experiment with newer, what I call second generation HRV biofeedback technology and equipment. So in my earlier pilot studies, we used more traditional first generation devices and approaches. So that meant we had some pretty expensive lab equipment.
Yeah.
We'd bring people into the clinic, into the lab. We'd hook them up to electrocardiogram, respiration sensors, and we would have them do biofeedback, with a computer setup. And that was great, and that was fine. We would have folks practice with handheld devices, but the thing I always concerned me was that limited the scalability, the potential
Mhm.
for
Yeah.
uptake of this intervention, because I mean, let's say let's say that it works, great, but then how many people are actually going to be able to access a provider who has
Right.
this training, who has this equipment? Like
Yeah.
it's not going to really have real world impact if people can't access it, even if it's like the most effective treatment ever. If people
Yeah.
can't access it, like who cares?
Right. Exactly.
But since we did those early pilot studies, some products are coming to the market that really allow for really high quality home practice
Hmm.
without the need for a clinician. And one of those products is the Leaf HRV Biofeedback device, which is out of the Bay Area. It's a US-based company founded by a guy formerly from MIT. And I like this patch because well, one, it's a patch. It's not a
Yeah.
handheld device. It's a wearable electrocardiogram device, the patch that you wear on your chest, and it syncs with a smartphone app, and it affords ad libitum as needed practice. So folks wearing the patch can practice as many times a day as they like. And the app
Right.
has a very cool interface and it's very intuitive. And there's sort of embedded trainings in the app. So you don't really need a clinician to learn to do this breathing practice. It's all sort
Yeah.
of baked in, which is really cool. But the other thing I really liked about that product when I was first exposed to it is it also works as a just-in-time intervention. And
Hmm.
folk researchers listening to this will probably be familiar with the idea of just-in-time interventions, but for those who aren't, it's just sort of this idea that we can have an intervention, often a digital therapeutic, that can monitor our, physiological states or emotional or affective states in the background passively and can provide some kind of prompt or intervention when risk is detected.
Yeah.
So the way this device does that is it monitors heart rate variability in the background using ECG. So all day you're wearing this
Yeah.
patch, it's passively monitoring your heart rate variability in the background. And then when your HRV drops in the absence of movement, which is often associated with stress response,
Right.
right? Maybe for people with addiction, craving, which is
Yeah.
stressful, it prompts the wearer to do a quick burst of biofeedback,
Great.
1, 2 minutes to get HRV back up. And so in that way, it's kind of potentially getting out in front of the risk.
Right.
So, if you're experiencing stress and stress is a risk factor for a relapse or a lapse to alcohol or other drug use, and you're in early recovery from addiction, and that's like something you really don't, it's
Yeah.
not somewhere you don't want to be going, then, this device could get out in front of that risk
Love
potentially
it.
and tip people off in the moment, dial them in, as it were, to their stress states which, for what it's worth, is like for folks in early recovery from addiction is a key vulnerability. Folks in
Absolutely.
early
Right.
recovery from addiction, one of the hallmarks of that time period is sort of a lack of self-awareness of affective states. This is like something well known to clinicians,
Yeah.
and it's a vulnerability we try and plug in clinical care. So what if, we have a device that can like signal to people in the moment. It's like, hey, you may be aware that you're pretty stressed right now, but you're pretty stressed, by the way. And like,
Right.
by the way, let's do a few minutes of paced breathing, get your physiology under control, and maybe that gets you through to the next moment.
Yeah.
And you're less likely to pick up
I
a
love
drink or a
that.
drug to deal with that stress.
I love that. And so, how long, were you? What? How long was the intervention going? What was the study period where you had them, the two groups going?
So we followed folks for 8 weeks, and we chose 8 weeks because we've done shorter studies of 3 weeks of HRV biofeedback that have produced benefit. The early protocols involved 12 weeks of
Yeah.
biofeedback training, and so we were kind of looking for the sweet spot in the middle, trying to manage participant burden, thinking about sort of real world conditions, like how long are people realistically going to be want to do this for. And so
Yeah.
we came to 8 weeks. We felt like that was a reasonable place to start. Again, that's sort of an empirical question that
Yeah.
we need to tease out in subsequent studies is like sort of what's the ideal amount. Um, but we settled on 8 weeks. So we followed we had folks in the biofeedback group do 8 weeks of HRV biofeedback. And we told them like, wear the device every day. You don't have to wear it
Yep.
all day. You're not sleeping with it on. Try and wear it most of the day when you're up and out. Try and do 10 minutes of scheduled practice, five
Okay.
minutes, 5 minutes, 5 minutes in the
Yep.
morning, 5 minutes in the afternoon, and try and get in about 5 minutes of practice in response to the cues when the
Great.
device is signaling, like just in time practice is
Yeah.
indicated. Or if you're just feeling stressed and maybe the device doesn't catch that, or you're having a craving and you just need some help writing that, use it then as well. And
Yeah.
we wanted folks to do about 15 minutes of practice because we know from a previous pilot study that about 12 minutes of daily practice seemed to be the sweet spot for reducing anxiety. So we
Interesting.
really done
Okay.
studies around that. We knew 12 minutes was probably like an important threshold people needed to be at. And so we wanted people hitting that. So we kind of felt
Awesome.
like they were getting a therapeutic dose.
Yeah. Because that's always the question that I hear different things about what is that magical, and probably, customers I talk to who are starting biofeedback, it's like, what is the magical
What's the sweet
number?
spot, right?
So that 12 is key because is it 20? Is it I've heard 2 doses of 20 minutes, which and then everybody says nobody does those, so it's
Mhm.
like
Yeah.
we can knock that down like it's 40 minutes, but nobody in the world will
Just got to
ever
do
do
it. Less is more.
it. So it's a very interesting metric to kind of chase and try to figure out
Mhm.
with that as well. So, one of the interesting things, as we get into the results, I'll just read from the summary I got here. In contrast, the control group experienced increase in both negative affect and craving. So one of the things like that just kind of, even though I was like, nerding out about the experimental group,
Mhm.
this just kind of hit me like a ton of bricks of okay. I guess I'm left with the question, and I always position HRV biofeedback, especially with the second generation devices that we're talking about, as homework, as like you said, a supplement. What's going on with the control group, my friend? I just got to ask because if they're getting treatment as usual, we would hope we would see improvement of symptoms in treatment as usual, but that's not what you found.
Yeah, and of course, there's a lot of variability in what people, how much treatment folks are engaged in.
Right,
Again,
right.
we wanted to have a naturalistic sample, so we didn't tightly control that.
Yes.
And of course, like when we look at these trends, that's at the level of the mean, sort of on average as a group. The control group was showing increases in negative affect, which included stress and nervousness, anxiety, and
Yeah.
so symptoms of depression and craving. Um, uh, that wasn't necessarily everybody's truth. I mean, some folks in
Sure.
that group saw reductions, but on the level of the mean, the group was showing increases. Whereas conversely, as you alluded to, the experimental group, the HRV biofeedback group, on average saw reductions over
Yes.
that time. And I should add as well, we didn't just sort of look at pre-post levels of negative affect and craving. We were using ecological momentary assessment. We were surveying people twice a day using a smartphone app that would ping people twice a day and ask them like, rate your stress, rate your happiness, rate your
Yeah.
nervousness, rate your craving. And so we had these really granular repeated measures of affective states um, over the 8 weeks. And so we were actually really able to do some more sophisticated
That's great.
analyses and look at these sort of more sort of granular changes in negative affect over the course of the study. And that's an advance in clinical research and in randomized controlled trials, because it used to be we would just say, give people a questionnaire at baseline and then give them a questionnaire at the end of
Yeah.
treatment and maybe over follow-up. But we never really captured the ups and downs and the granularity of what was happening in treatment. Whereas with ecological momentary assessment, we were really able to drill into
That's
that
awesome.
in a much more granular way and see these trends.
I love that. So I'll let you knock out something that just popped into my head because it would almost seem like treatment as usual, uh, was causing more cravings and negative affects. So I appreciate what I'm going to say is wrong after this, but I mean logically, if you just did the HRV biofeedback and didn't do anything else, that you'd get better outcomes. I mean, I kind of think I'm putting one and one together here without. And I'm not encouraging anybody that's treating a substance use disorder to stop treatment. But yeah, but just like from a research perspective, is treatment as usual, is it, I don't know, like I would not never want a client going through my treatments to experience, increased cravings and negative increase in negative affect. So I just kind of wonder, like, I'm assuming you're not, and I no way am I putting these words into your mouth because I wouldn't say them outside speculation. What's going on here? Like,
See, I interpret it differently. The way I think about this is, it wasn't that treatment as usual was causing increases in craving and negative affect.
yeah,
That's probably a phenomenon that was happening anyway, and that
yeah,
treatment as usual just probably wasn't managing it as well. Now, these were folks in the first, they had to be in the first year of a current recovery attempt, but many were just
yeah,
sort of initiating a recovery attempt.
yeah,
And so it's important to note that in very early recovery from addiction, often we do see increase in negative affect and craving. We would expect that
yeah,
because, for one, folks have probably relied on alcohol and other drugs to cope with negative affect, and
right.
now they don't have that. Suddenly,
Yes,
they're like, that's not a tool, that's not something they can use because they, now have an abstinence goal and are working towards that. Um, so, and of course, we would also expect to see increases in craving at
yeah,
that time as well. So it sort of makes sense that they're going up. What this probably speaks more to is the capacity of HRV biofeedback
yes, yes,
to help people manage that stuff. So it's not like the message isn't like treatment as usual. We should give up. And in
right.
fact, it's iatrogenic. It's causing more problems than it's solving. Like, I don't think that's what's happening. I think we're just seeing that, that probably the experimental group, had they not have gotten HRV biofeedback, probably would have shown a similar trend.
Yeah,
But because, the HRV biofeedback was helping them manage that negative affect, we were seeing reductions.
yeah. What do you think? And I always want to make sure speculation here because I know this. If we would just, just again, total speculation, play this out for 12, 16, 6 months, would you just kind of speculate, not because we don't have the data to show this, but would you kind of see, I would say, cravings with the control group eventually start to and negative affect trend downwards or in a positive
Absolutely.
direction for these two negative outcomes?
Yeah.
But I would assume that since the HRV biofeedback would just keep being kind of ahead of that curve for people, again, knowing that we're speculating here, that it would just kind of maybe accelerate the recovery, if that's not too much of a powerful speculation on my part.
It's- you sort of highlight an important point here, right? And we know, so on average, people in the first year recovery from addiction, often we do see increase in craving and negative affect early on, but eventually that it gets better, it ameliorates, right? With
Yeah.
time, as you would expect, like
Yes.
things settle down, like, folks like, start feeling better. They're through, acute and chronic withdrawal syndrome they may be experiencing, they may be getting dialed into treatment, and
Yep.
their sort of social and psychosocial world is stabilizing, right? We see reductions in negative affect and craving, to be sure. Now the question is sort of, and we didn't have follow-up in this phase 2 trial it's a phase two trial, and that's something we usually save for phase three. So, we don't know, whether this HRV biofeedback, like if those gains would be sustained. Well, the way I think about this is like if this is a tool that maybe helps people ride out, like,
Yeah.
the early, phase of recovery when negative affect and some craving can be a potent trigger for relapse. If it could help folks get over that hump, maybe they've got a greater probability of getting to that 6 month mark, 3 to 6 month mark,
Yes.
where they do start naturally feeling better. So in that way, it could be bridging people.
Yes.
That's an empirical question for a phase three trial. We need to ask that question and have a follow-up period to really see if the benefits are sustained. But that's what I suspect is, there's going to be potential like long-term benefit. If there is long-term benefit, it's probably because even if people stop doing the biofeedback after 8 weeks, that's going to help bridge a lot of folks, not everybody, but a lot of
A
folks.
lot of folks, yeah. Yeah, because
Yeah.
like you said, such a vulnerable time for folks. I wonder if you saw, maybe, how maybe you tracked this, maybe you did, but like, were you tracking sort of HRV, RMSSD, or high frequency? Were you kind of looking at, I don't know if the control group, probably not since they weren't on a device,
Right.
but I wonder if you got anything from the experimental group. Did you see sort of positive trends in the HRV data, even their biofeedback data? Did you see more low frequency over time? Did you see any of that in the research and data collection?
Yeah, so and that's uh you're speaking to some ongoing work we're doing. So we did collect from the ECG devices, we were able to collect interbeat interval data
Yeah,
and calculate heart rate variability statistics for the experimental group. But we didn't have the controls wear any kind of device. Right.
yeah,
Uh, Again, we were weighing burden with, like
sure,
benefit, and we just said, you know what, like for phase two, like what we care most, the primary outcomes are really substance use and negative affect and
absolutely,
craving. They were the big ticket items we're
yeah,
interested in. And yet we had access to that physiology data in the experimental group. And so we're starting to analyze that now. And generally, yeah, we are seeing our preliminary analyses, as you would expect, improvements in HRV in that group. Unfortunately, we don't have the comparator.
yeah.
So we're going to be a bit limited in what we can sort of the story we're able to tell there. But we do plan to publish those findings. One of the things we're sort of interested in is like, is it necessary to experience chronic changes in HRV to experience clinical benefit?
Yeah,
That's sort of an empirical question that the field has been asking. Because it seems like, initially in the early days of HRV biofeedback, it was thought that was probably the mechanism. You increase HRV, that leads to secondary benefits in sort of
yeah,
mental health and well-being. But we've seen in a lot of our studies that even though folks don't experience sometimes chronic increases in HRV, they still see reductions in anxiety, depression, stress, craving. And so, it's well may be that there's something more happening acutely in the moment when people are practicing that
yeah.
is affecting physiological change in the moment, that's having an effect on the brain, that's having a benefit, a curative, a benefit for the patient or the participant. That might not necessarily translate into resting changes in HRV,
Right.
right? So that's a question we're trying to tease out. And we'll start to get to that with this data.
Well, and obviously, I'm sure you would love to wave a magic wand and do this as well. It would be great to have like a few months while they were still using too. Like
Pre-post.
that would be like I'd love to see that data because that's the real baseline in many ways that would be, and I know that's a magic wand sort of data set that would be very, very, very challenging possibly to get to with folks, but that would be just to study that transition because I'm always fascinated, and if you have any thoughts on this, like the difference between, especially with biofeedback and HRV tracking, are we measuring states or traits? Like, because it takes a while. Neuroplasticity is just a beautiful miracle of
of
the
nature.
human nervous
Yeah,
system, and yet it's not, especially, once you get above the age of 25, it's not a very fast thing that happens as well. So sometimes, like HRV biofeedback studies that only go 4 weeks, it's like, is there, are we seeing any neurological changes in that time, with that? So that's always been something I've been fascinated with. Are we studying enough to see real changes in the nervous system? And I think, having a state of relaxation and emotional regulation is a powerful tool in of itself. But it's
absolutely.
just
Right.
interesting, that state or trait piece. I just kind of wonder if you had any thoughts of that with these folks that again are in a very vulnerable kind of position in life in their
Yeah,
recovery.
yeah. And this is a question, I really want to tease out in future studies is like, not just sort of how much people, I want to know how much people need to be practicing each day to get benefit, because
Yeah.
that obviously informs clinical guidelines. And the less the better, right? The more likely people are, the less they have to do, the more likely they are to practice. So if I can
Yes.
tell people just do 12 minutes a day, that's going to be enough. Like that's much better than just saying, well, I'm going to have everyone do 40 minutes a day, knowing they'll never do that, and they might
Yeah.
just not even try,
Yeah.
because
The,
it
the
seems like,
world, Dr. Eddie, is waiting for that result. So,
yeah. But I want to know sort of like also sort of,
yes.
um, in terms of sort of sustained practice, like, for addiction, especially because that's my area of focus. Like, is it enough for folks to do an 8 week burst of HRV biofeedback, and that's going to, on average, bridge folks to their next
Right.
phase of recovery, and and maybe then after that they just sort of use it sporadically, because once you learn this breathing practice with biofeedback,
Right.
most folks after a few weeks internalize it, and they can go into the breathing practice
Yeah.
without any kind of equipment. And
Right.
so in that way, it could be a potent tool that people carry with them through the life course at no
Yeah.
cost, with no downside, no bad side effects, no contraindications. So in that way, maybe folks aren't practicing every day, but it's still a tool they have in their toolbox to manage acute stresses when they arise.
Yeah.
That could still be a useful tool for people on their long-term recovery journey. Maybe people just can stop practicing altogether, and there's still benefit that they've been
Right.
bridged. Maybe people actually do need to keep doing it regularly to get sustained benefit. That's the
Yeah.
question we need to address in future studies. We don't know.
Yeah. I'm curious, one, any findings we haven't talked about that we should, and two, I don't know if there was any kind of qualitative data of, what you heard back. I mean, obviously you were collecting data on affect and cravings, but just kind of anything maybe qualitative that came up along the way from the experimental group as well.
Yeah, so a couple of things. Firstly, yeah, there was another key finding we haven't talked about yet, and that was that we saw significant reductions in substance use
Yeah.
in
Yes.
the experimental
Kind of.
group.
I probably should have led with that one.
Yeah,
Yes.
well, we were getting there. We're getting there.
Yes.
Um, and here's the interesting thing. Like, I mentioned that we asked folks to do about 15 minutes of practice a day. That was our goal. Like, only about like 25% of the sample did that 50% of the time.
Yeah.
Right. And so, like, most folks were sort of like um, under threshold for dosing.
Yeah.
And yet we saw a 64% reduction in substance use in the experimental group, like non-trivial, large effect size reduction
Huge.
in the probability of day level substance use, any alcohol or other drug. And so then, pair those two findings together. Like folks weren't practicing as much as we asked them to, as much as we thought they needed to.
Yeah.
And yet we were seeing like these significant reductions in craving, negative affect, and substance use. So what that makes me think is that it wasn't so much how much people were practicing, it's when they were practicing,
Yeah.
how they were using it, and what we were able to explore, because we had EMA,
Yes.
ecologically momentary assessed data. We were actually able to look at these more granular day level associations between craving and substance use. And
Mm.
so we were actually able to determine in our statistical models that the people in the experimental group getting biofeedback, they did experience craving, but they were significantly less likely to have substance use later in that day when they
Yeah.
had craving earlier in the day than the control group.
That's
And so
awesome.
what
Yeah.
we were able to infer from that is that folks they were using the biofeedback in the moment when craving was arising, which is kind of what we told them to do. So that's
Right.
good. But they were using it strategically, and it was helping them probably ride out those moments of
The cravings.
craving and getting through the day without picking up alcohol or other drugs. Whereas the
Yes.
control group didn't have that in the moment tool. Now, maybe they were getting some in the moment tools from, if they were doing cognitive behavioral therapy with their
Right.
therapist, but not
Yeah.
everybody was. We weren't controlling for that.
Yeah.
So it seemed like what really mattered was that people were using it in the moment, and
That
it was
tool.
helping bridge them, which was really one of our hypotheses leading into this study that
Yeah.
we speculated people would be using it in the moment, and that I based that hypothesis on my previous studies where I'd gotten feedback from participants. Like even though we weren't really assessing that, and they were sort of old school studies where we were just doing pre and post
Yeah.
questionnaires, but participants were telling me, when I meet with them each week to do biofeedback with them, they were telling me like, I'm using this in the moment. Like I noticed I felt like I was about to have a panic attack, and I did a few minutes of breathing, and it
Yeah.
stopped the symptoms, and I felt like I had control. So I was already thinking like people are probably going this is probably how people are going to use this and have derive benefit. And so that played out. And then in in terms of the qualitative findings, we did do some focus groups with participants, with a small group of the participants, about 10 folks, two focus groups. And we asked people like, what did you think? Like, did you like the device? Did you
Mm.
not like it? Was there things about it that that you liked that were annoying, that you would change? We just wanted to like tell us what you think.
Right.
Like, and did it help? Did you feel like it helped?
Yeah.
And by the way, were the prompts from the device helpful or were they annoying?
Yeah.
Like, I mean, for me, I just wanted to know. Like, I've got no like financial investment in like this
Yeah.
company or like the Leaf device. Like I think it's a great product, but like, I just want to know like, what did from a subjective point of view, from a participant point of view. I
Right.
mean, the data look great, right? But like, what do they think? And they
Yeah.
told us that one, they like the device, they like, they like the feedback. They really, really felt that the just-in-time prompts helped them increase their own sort of self-awareness of their stress and to sort of also start to see how much they experience stress in their body. So it
Mm.
was really like, in a way, this is not the goal of the device, or, this wasn't sort of part of the plan, therapeutic plan. But sort of a side benefit was it clearly seemed to be helping people increase their self-awareness of
Right.
risky moments.
Awesome.
And also, of course, was giving them something to do with that risk
Right.
in the moment. So it's a double win potentially. And so generally the feedback was super positive. Now, take it with a pinch of salt. Like the people who agree to be in these focus groups after a study tend to be the folks who either really liked the intervention or really
Yes.
hate like, and people who are like so about the
Yes.
invention usually are like, no, it's all right. Like I
Yeah.
don't feel like I have that much to say about it.
Yeah.
So, and usually it skews towards people who have nice things to say.
Yes.
So, take it for what it is. Like there was obviously like there were certainly people who probably didn't have that experience, right? So there's that. But overwhelmingly, the feedback was like, yeah, this is great. It was comfortable to wear. Like, there were some issues with like, you know, um, charging. A few people noted like some pretty small stuff, like in the greater
Yeah.
scheme of things, kind of stuff we see with digital therapeutics
Right.
more broadly. But the feedback was overwhelmingly positive. We want to publish those findings as well.
That's
Yeah.
awesome. Well, that kind of leads me here to my last question of, we talked a little bit before we hit started. Funding for research in the United States is a very fraught topic. So without getting too depressed, between the two of us, where would let's just say funding's going to happen because this research needs to continue. I'm sure all of our listeners would agree to that. Where do you want to take this? What are some of the next questions or study designs that you mentioned a few of them. Are we going to go to the stage three? Like, if funding is not an issue, which I know that's we're going to fantasy land right now, but like, what are your hope for next steps?
Yeah, yeah. Look, yeah. And funding's always the thing, isn't it? It's always a challenge.
Yep.
I mean, we're so fortunate in the United States to have the National Institutes of Health. I mean, no
Yes.
other country really has that kind of like the power to and the infrastructure to support research and the way. So we are well situated. Even though there are challenging times with federal funding, and sort of we're in one now. The NIH is still a powerful force for good. Uh, and they funded the phase two trial. The National Institute of Drug Abuse funded that study, and that was um, uh, funded through what we call it was called an R21 mechanism, which is really sort of a pilot phase two
Mhm.
um, grant mechanism designed to collect preliminary data. So that's the kind of grant you apply for if you don't have preliminary data. You think you've got a good idea, an interesting intervention, and there's a pretty good theoretical basis for it. You can sort of like sell to pitch to the reviewers and get their buy-in, and you can get a little bit of seed money to do
Yeah.
that preliminary trial. And then if that preliminary trial shows positive results, if there's a signal there, a potential benefit, then you go back to, and say, all right, look, there's clearly something going on here, like some good.
Yes.
Um, this is worth looking into more. This is worth, funding a phase three trial. And that's where we're at now. So we're going back to NIDA now with a new application for phase three funding. We're saying, look, the data look really good. We
Yeah.
just published the results in JAMA Psychiatry, and it's exciting. But more, of course, more data is needed, more research, like before we can say with conviction that this has efficacy, and should be something physicians and clinicians recommend their patients utilize. And so, that's under review now, and with a bit of luck, that gets funded, and we will, be doing the phase three trial, but perhaps starting sometime next year.
My fingers, my toes, everything is crossed because, like I said, you see even like some papers that I like that just kind of fizzle out, and this has caused really great waves in kind of that secondary market for research and in getting the word out there. Like just I don't know, it's a beautiful study. Like I don't use that word a ton when I read this, and I was just so thrilled that I knew the primary author, and I might have a chance to do this interview with you. So hopefully we can help be a little bit of that secondary push to get this out in front of people because yeah, like you said, like having done work around substance use in a couple different settings, like it is such a vulnerable time and relapse, especially with things like opiates and fentanyl. Like, even with alcohol and other things, it can be life threatening, if not life ending.
It's life and death.
So
Yeah.
that support and during that vulnerable time, I just think could not only improve our outcomes, but potentially save lives as well, which is just so exciting to see this in practice in that way.
Absolutely, absolutely. And like, look, more research is needed. But at this point, sort of the recommendation is based on what we're seeing, like there seems to be benefit here.
Yes.
And so, because this intervention doesn't have any adverse side effects,
Yeah.
it doesn't have any contraindications, which mean it doesn't mix poorly with other treatments
Yes.
or medications. It's relatively safe, we think, from
Yeah.
previous trials. Uh, you know, this is something, it's probably something, for folks in early recovery from addiction, there is potential benefit,
Yeah.
to trying this out. Now, I wouldn't say like, I'd say keep doing the other stuff you're doing too.
Right.
I wouldn't, the
Oh, for
data,
sure. Yeah.
in the phase three trial, we're actually going to have three conditions. So we'll have HRV biofeedback alone, CBT alone, and HRV biofeedback with CBT. And what we
Oh,
really want to see is like, does CBT and HRV biofeedback together produce added benefit? Or, perhaps is like HRV biofeedback alone enough? Like
yeah.
I suspect not. Like, I think there's probably like, a wraparound treatment like CBT is really going to confer a lot of benefit. And I don't think HRV biofeedback can replace that. But again, it's a question.
Yeah,
We have to wait for the data to tell us. We
yeah,
can't just, we can have hypotheses. We should have hypotheses, but we can't know. But at this point, the data look, really promising. And because there's really no downside to HRV biofeedback practice, it is something I would recommend, people look at if they want to
yeah.
supplement what they're doing currently.
Yeah. Well, and like I said, without the danger, I'm sure you see this too. It doesn't work for nothing works for everybody.
Right,
Like
right.
we have not found that intervention that works for everybody. So at a very affordable price point for the long-term benefits is can you integrate HRV biofeedback? And you may have some people who do it once and just don't ever do it again. You may, but if there's a 60, 70% uptake of people using it, especially again, and I think also positioning it as, hey, let's get through this vulnerable time. Here's another tool in your recovery, that's helping, give them a little psychoeducation on their nervous
Little bump.
system, create, lower cravings and, so many relapses too. There's a lot of complexity around this, but a bad
Oh,
mood, whether you're tired, grouchy, hungry, like all
yep.
those triggers, like you're addressing both the craving side and some of those, other, states, if you will, that can lead to relapse. And, a tool that does both of those, like I said, I can't think of better homework. They can still journal because we always like to get people journaling. But I can't think of better homework to give people. And this study just really, I think, opens that door to giving us the data we need to really advocate that this, for programs to offer this as at least an option or part of their programming for folks.
Yeah, yeah. That's it.
Dr. David Eddy gave the world a huge gift here. If you talk to your co-authors, please pass on the thanks from us HRV nerds out here in the world that
Will
gobble
do.
up this research. So we'll put a link to the article in the show notes for everybody, as well as information about you as well. And like I said, if you're interested in this conversation, going back to our previous conversation, I know we do a deeper dive into, some of your work specifically around that as well. So a great compliment to that. And you got to promise me when stage 3, you start getting some good data and good conclusions from that. I'm sure me and my audience cannot wait to have that conversation.
I'll be back. Yeah.
All right. Thank you, my friend. As always, you can find show notes, information, links at optimalhrv.com. Thank you, everybody, and have a wonderful week.